For the past 2,000 years, pain has been a pain, and it's something that patients struggle with and practitioners struggle to treat. The word pain is derived from the Greek term poine, meaning penalty or punishment. We now understand that pain is actually not a punishment. It is a complex state that involves neuroreceptors, nociceptors, and sensory inputs. So sort of understanding the background of pain is going to help you as a practitioner make the best choices in pain control. Pain is a common complaint among all patients. It's difficult to define, it's difficult to quantify, and that makes it difficult to treat. Patients are going to experience pain, and it's our job as healthcare practitioners to control the pain to a manageable level and then educate our patients with respect to their expectations for pain control, how analgesic medications are going to work, and the side effects that patients can expect. So it's important for a practitioner to know a couple of agents inside and out so that they can offer the best counsel to their patients and the best guidance to their patients when talking about both acute and chronic pain control. You can't begin to treat pain unless you understand how to assess and define pain. And so assessment of pain is necessary to ensure that an adequate pain control is achieved for a patient. Knowing what questions to ask your patients about their pain will help you choose the best medication to treat that pain. And your understanding of pain is really paramount in helping the patient set expectations for their pain control. If you think as a practitioner that pain is something that can be turned on and off for all patients, has definite markers or definite triggers to cause pain, that all patients perceive pain the same way, you're very mistaken, and it's going to make you a less than optimal practitioner when we're talking about pain treatment. So how do you assess pain? It's actually, if you can get this PQRST into your mind, it becomes very simple at appointments with patients or even phone calls with patients to quickly assess their pain and to know sort of the key buzzwords that you're looking for when patients are describing their pain to you. So the baseline assessment involves P, palliative and provocative factors. What makes the pain better or what makes the pain worse? Q is for quality. Describe the pain. Tell me, is it burning? Is it stinging? Is it dull and aching? Is it sharp? The radiation obviously leads us to believe, where is the pain? Can you localize it to one spot, or do you feel that the pain is in a primary spot but spreads out to other parts of the body? S stands for severity and intensity. How does this pain compare to pain experiences you have had in the past, or how does this pain compare with itself from day to day or from time to time? And then lastly, T stands for temporal factors, which is really the how does the intensity of pain change with time? Is it worse in the morning when you wake up? Is it worse when you're lying down? Does it wax and wane throughout the period of a day? So knowing the PQRST, how each of these letters helps you kind of dig deeper into a patient's complaint of I have pain, makes you a really good practitioner, because you're going to be able to take these points and drive therapy towards the PQRSNT of the patient's pain complaints. Another way to assess pain is a numeric pain scale, and this is sometimes easier for patients to give a number of how bad their pain is, but to be honest with you, patients need to be taught how to use this scale properly. I've had some discussions with practitioners that post-operatively they'll go in to see a patient and the patient will say that a pain score of 10, which 10 is defined as being the worst pain imaginable, will be sitting comfortably in their bed, enjoying their breakfast, flipping through the channels, looking for Judge Judy or something of that nature to watch. Really, on a numeric pain scale, a pain score of 10 should be accompanied by physical signs that indicate that that patient is experiencing that level of pain. Physical signs of a 10 pain should be hypertension, tachycardia, sweating, shallow breathing, fast breathing, writhing in pain, clenching or protecting of the painful area. A patient reporting a 10 level of pain should not be incredibly comfortable and without any outward physical signs that they're experiencing this level of pain. If we look then at a picture of the numeric pain scale, we see that it's split up on this slide as 0, 5, and 10. So 1 to 3 is classified as mild pain. And this is going to be helpful because we're going to talk about specific agents that fall under each of these pain categories. 4 to 7 then is categorized as moderate pain, and 8 to 10 is categorized as severe pain. Now I'll tell you, both acute pain and chronic pain can be measured with the numeric pain scale. You would hope that someone with chronic pain isn't living at an 8 to 10 score of chronic pain, but there are likely periods of their pain management that will fluctuate between probably mild and moderate pain levels to periods of severe pain. So this can be applied to a spectrum of a lot of different patients in various states of pain control and needing analgesia. So I'm making pain control sound kind of easy. And so as a practitioner, you might think, well, geez, I've figured out how to assess their pain. I understand mild, moderate, and severe pain. It should be pretty easy for me to treat a patient's pain. But pharmacologic treatment of a patient's pain is only one piece to the puzzle of achieving pain control. There's a lot of misconceptions about pain, and a lot of it stems from the fact that the medications we use to treat pain, especially in the moderate to severe categories, are quote unquote big hitters. And frankly, they scare people. In 2011, the CDC reported that more than 40 people die every day to overdoses of prescription painkillers like OxyContin, Norco, which used to be called Vicodin, and medications like that. That's probably overt misuse of those medications. That's not from people that are taking these medications responsibly for pain control. There's a huge misconception that using opioid pain agents leads to addiction. There's a lot of expert opinion and data out there that says no, appropriate, monitored, controlled use of controlled substances actually does not lead to addiction and treats pain better than folks that sort of nimbly-pimbly treat their pain for long periods of time. Those folks are actually at a higher risk of addiction and dependence on pain medications because they've never really nipped the issue of the pain control in the bud. So let's talk a little bit more generally about barriers to pain control. The perception of pain varies from patient to patient. So pain's really subjective, and it's affected by physiological, psychosocial, cultural, and environmental factors. For example, our behavioral response to pain is part of our reaction to pain, is learned. So if your parents are really tough and they tolerate pain really well, and maybe they just bite on a leather belt when they're in pain, you might think, I don't need pain meds. I'm a Smith. I can handle pain without that. Cognitive is that there are some thinking processes that alter pain experiences. Perhaps depressed patients or anxious patients will sort of exaggerate or over focus on their pain, making the pain experience more than it is, or making that pain more painful, if you will. Oftentimes there are social barriers to pain control. So the way patients express pain or talk about their pain differs in accordance with their social environments, or kind of what's acceptable. And that flows into cultural barriers to pain control as well. Sometimes a culture can influence a patient's pain tolerance or a patient's acceptance for pain medication. Patients also have misconceptions about the levels of pain that they're experiencing and the degree of relief that can be achieved with that pain. There are some situations of acute pain where you're never going to get to zero. Our goal is to get you as comfortable as possible so that you can continue to participate, for example, in physical therapy, perform your activities of daily living. And in chronic pain, the expectation to take someone who truly has chronic pain to no pain at all, that's not realistic. So patients will have a barrier to pain control because their expectations are just not aligned with what's physically possible. We know too that anxiety, depression, fatigue, anger, and fear can lower the pain threshold. And when people are rested, have sunny moods, experience sympathy from those around them, can divert the focus or the attention on their pain. All of those things raise the pain threshold. Sometimes patients too will report just having someone note that they understand that they're experiencing pain, or they appreciate that that patient is experiencing pain, can help raise that patient's pain threshold. So we can see that a lot of these things don't directly relate to analgesic therapy, but are outside factors that really contribute to a patient's perception of treatment for their pain. So what's the textbook definition of pain then, Kate? You've talked a lot about pain. You've told us how to assess it, what it is, what it isn't, factors that can affect it. Pain, currently, the definition in the dictionary is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage or described in terms of such damage. The cut and dry of it, though, is that pain is very subjective, and often it's defined as whatever the patient says it is. So we want to wrap up pain into a really nice bow. We want to be able to PQRST it when we're assessing it. We want to be able to put it on a numeric scale or a visual analog scale, but sometimes we are at the mercy of our patients in what they tell us pain is. So we have to both listen to them and then employ our therapeutic scientific knowledge to help them understand what we're going to teach them about their pain and their options for pain control. The mechanism of acute pain is that it is a nociceptive pain. Nociception in pain is a combination of true chemical conduction of pain and then the sensations and perception of the chemical stimulation that occurs. It's classified as either somatic or visceral, and it involves stimulation or sensitization of the nociceptors, which results in the release of neurochemicals that potentiate further sensitization or stimulation. Nociceptive pain involves multiple neuronal tracts throughout the body and the brain. And to help clear something up here, when we said it was classified as either somatic or visceral, somatic means arising from the skin, bone, joint, muscle, or connective tissue, whereas visceral means arising from the internal organs, such as the large intestine, the liver, the pancreas, things like that. So sometimes as a patient describes pain, in your mind, you'll be able to think of it then as either somatic or visceral. If we contrast then nociceptive pain to neuropathic pain, neuropathic pain is pain that is defined as sustained from abnormal processing of sensory input by the periphery or the central nervous system. It's more vague and generalized in its description. It's harder to duplicate and evoke. And when patients describe neuropathic pain, they often describe it as constant and achy. There are 4 processes that are talked about in the book that are required for pain to occur. They are transduction, transmission, modulation, and perception. So a lot of those are pretty obvious. The one I want to focus on for a minute, though, is modulation. Modulation is inhibiting the pain transmission, and that can occur by a number of different mechanisms. Pharmacologic, which obviously we're going to talk about pretty extensively in this lecture, cognitive, and behavioral. So an example of a non-pharmacologic modulation is actually physical therapy. If a patient who has chronic pain is seen in the office, a referral to a physical therapist may be beneficial because those practitioners can actually teach patients ways to move and exercises that can help them control or limit painful experiences. So sometimes in modulation, which is really the solving of the pain problem, we need to think outside the box that's right in front of us, which is going to be the drug box. What can we give this patient pharmacologically to help cure their pain? Later in the slide, we're going to really briefly touch on cognitive and behavioral and other non-pharmacologic ways to modulate pain. But I wanted to point out the referral to other health care practitioners because sometimes we forget about that. And I think it's an important point to remember. So now the bread and butter of this lecture, the pharmacologic treatments for pain control, also referred to as the analgesic ladder. If you look in the literature, the analgesic ladder is used to describe and treat cancer-related pain, but it's really useful in any sort of pain treatment regimen. What it does is it categorizes pain on 3 levels and then associates appropriate pain medications to treat those levels of pain. So mild pain is treated with mild painkillers or anti-inflammatory drugs. We will most commonly think of the NSAIDs like ibuprofen or acetaminophen falling into this category. Moderate pain then can be treated with weak opioid painkillers, and examples of that would be codeine or hydrocodone, and severe pain is then treated with strong opioid painkillers. An example of that would be oxycodone. So we can put together now our numeric pain scale, which is 1 through 10, and the categorization that 1 to 3 is mild. We now have specific agents that we should be thinking of to treat mild pain. 4 to 7 is moderate pain. Again, our brain should go to those agents of codeine or hydrocodone. And lastly, severe pain, which is an 8 or 10 on the numeric pain scale, and oxycodone should pop into mind for those patients. We know that there's a lot of different mechanisms by which pain is caused. So combination therapy is oftentimes very helpful to target the various mechanisms that can contribute to pain and the perception of pain for patients. Reassessing a patient's response to the medications that are prescribed helps avoid the issue of continued inadequate pain relief. So we have to be mindful that the analgesic ladder sort of gives us an idea of where to start and where to move, but it doesn't work for all patients. So as an example, if a patient has mild pain and you start them on a regimen of ibuprofen and they note that it isn't working, then that agent needs to be stopped and another agent needs to be given a trial run. It doesn't often work to just throw something on top of the ibuprofen because now we're exacerbating potential side effects. A patient is taking a medication with really no indication. The ibuprofen isn't helping the pain. So sometimes it is worthwhile to stop an agent and to move to a new agent altogether. Let's focus in then on each of these categories and the agents that fall within them. So agents to treat mild pain: NSAIDs, ibuprofen, which is Advil or Motrin, naproxen, which is sold over the counter as Aleve, meloxicam, which is the brand name, or is the generic name, excuse me, for Mobic, and then celecoxib or Celebrex. Those are the ones that I think if they're in your arsenal, you can extrapolate their information to the other NSAIDs if needed, but those are the ones I most commonly see in the practice of internal medicine. The mechanism of action for NSAIDs is that they inhibit prostaglandin synthesis in response to noxious stimuli, and in doing so, they decrease the number of pain impulses that are received by the central nervous system. Additionally, the blocking of the COX-2 enzyme results in the decreased inflammation that can occur in pain. So one of the agents that I have listed above, celecoxib or Celebrex, is a purely COX-2 selective agent. There was a lot of buzz probably 15 years ago about COX-2 selective NSAIDs. They had a lot of cardiovascular adverse effects, however, so the majority of them have fallen off the market. Celebrex is the only one that remains as a COX-2 selective non-steroidal anti-inflammatory drug. Acetaminophen also falls under as an agent to treat for mild pain, but we'll get to its details in the coming slides. I think this chart is helpful to refer to because it's important to understand how quickly patients can expect to experience pain relief from NSAIDs, what time these agents peak in, and then how long can we expect them to work, which helps you determine how frequently you need to prescribe an agent if a patient is going to be using it quote unquote around the clock. We also need to know how long they work for as needed dosing so that we aren't instructing patients to take them too close together. So in general, these agents will begin to provide analgesic relief in about a half hour to an hour. They peak anywhere from about an hour to 5 hours. So the more commonly available over-the-counter agents, Aleve and Motrin, for example, will peak in about an hour or two, whereas Mobic is much longer acting in that it doesn't actually reach its peak efficacy until about 4 or 5 hours after it's dosed. When we think about analgesic duration, then we can kind of recall some commercials for this. The Aleve commercial says, why would I take 6 Tylenol in a day when I can just take 2 Aleve? So they offer relief generally for 12 hours. Thus, BID dosing is most appropriate with naproxen or Aleve. Meloxicam can be dosed much less frequently. It's not uncommon to see this agent maybe dosed only once or twice daily because its analgesic duration is up to 20 hours. So it's important to not memorize these facts, but as you use these medications more often, you'll kind of commit them to memory just by default. But I think it's good to have somewhere where you can reference the onset, peak, and duration rather quickly. It's important to note that there's a great deal of interpatient variability with NSAIDs. What works for one patient is not necessarily going to work for another patient, and it is also worth trying a couple of different NSAIDs in a patient who is presenting with complaints of mild pain, because while they may not respond to ibuprofen or even Aleve, they may be a better responder to Mobic or Celebrex. It usually takes about 2 to 4 weeks to really evaluate the efficacy of a given NSAID because there is a delay in achieving the true and full anti-inflammatory effect. And then it's also necessary to give these agents, fair time to see how they work, because pain the variability of the symptoms will fluctuate from day to day or even from week to week. So this shouldn't be something that a patient tries for a week and then gives up on entirely. You haven't given it a fair trial if that's the kind of mindset a patient has. To further define acute pain, we can sort of think of NSAIDs to be used to treat any condition that's associated with inflammatory mediated pain. And the common thread to all arthritic conditions is inflammation, so it's not uncommon to see NSAIDs as part of a treatment plan for a patient that has arthritis or arthritis-related pain. In general, NSAIDs are typically well tolerated. We educate patients to take these medications with food, and that's to help minimize the GI effects, because I think the most probably aggressive adverse effect, if you will, of these agents is the GI irritation, the nausea, the abdominal pain, the dyspepsia or acid reflux, and the risk for GI ulceration with these agents. Additionally, patients taking NSAIDs can complain of edema, which is swelling, itching, dizziness, or headache. We do have to avoid the use of NSAIDs in patients with significant renal insufficiency or renal dysfunction, and that's because kidneys that are impaired rely on prostaglandins to cause vasodilation. And if you remember, NSAIDs inhibit prostaglandins. So if you don't have prostaglandins, vasodilation is lessened and blood flow to the kidneys is decreased. So it causes sort of like an ischemia picture for the kidneys, and long-term ischemia can result in tissue death. So patients that have impaired kidneys and take NSAIDs regularly or even frequently but for a short course can actually cause additional kidney damage. If a patient has had prior GI issues, it doesn't mean that you have to avoid NSAIDs altogether in those patients. Some patients may do very well in using NSAIDs if you also prescribe an H2 blocker like famotidine or a PPI product like omeprazole. The reason that we see so many GI adverse reactions with NSAIDs is that prostaglandins, when they're inhibited, will cause increased gastric acid production. So you're just increasing the risk of mucosal damage because you have more gastric acid available in patients that are taking NSAIDs. A common agent that's used to treat mild pain would be acetaminophen or Tylenol. Its mechanism of action is that it inhibits the synthesis of prostaglandins in the central nervous system, and it peripherally blocks the pain impulse generation. The time to effect or the onset of action for acetaminophen is generally less than an hour. It has a duration of about 4 to 6 hours. It really doesn't have any appreciable common side effects when we give patients Tylenol at prescribed doses. Now, when we start to reach maximal doses and exceed maximal doses, the most obvious effect of Tylenol is liver damage. But in day-to-day reasonable use of acetaminophen, we should be able to avoid that. However, about 18 months ago, the labeling was changed for all Tylenol-containing products to limit outpatient or home use of acetaminophen to a max of 3 grams per day. So that would be a total of 6 extra-strength Tylenols, since they're each 500 milligrams apiece. That was because there was misconception among the general public that Tylenol was devoid of really any sort of risk, and so patients were taking prescription medicines that contained Tylenol. They were using over-the-counter Tylenol, and they thought if a little Tylenol works well, a lot of Tylenol has got to work better. So now the recommendation for patients self-treating with Tylenol is not to exceed 3 grams per day. In the hospital setting or in the setting of Tylenol prescribed by a practitioner, 4 grams as a maximum daily dose is still appropriate, because those patients are being monitored more closely for adverse reactions or for overuse, and practitioners are hopefully checking in with patients more often and educating them that if they're going to be taking 4 grams of Tylenol a day, they have to be very mindful of how they're getting that through prescription medications combined with over-the-counter use. I feel like I had to include this slide because if I didn't, the entire chapter of acetaminophen in the book would have been for naught. They chose to focus on acetaminophen and its use in control of fever. So to touch quickly on that, acetaminophen is the treatment of choice for fever. It's noted that really fevers greater that fevers less than, 104 degrees Fahrenheit do not need to be treated. Symptomatic relief is provided when fevers are greater than 104 degrees. And we need to be kind of mindful of that because elderly folks can experience tachycardia from fever. And most elderly folks have CHF. So if they're experiencing tachycardia, that could actually lead to a CHF exacerbation. And we have to be mindful too of high fevers in pediatric patients because fever-induced seizures is something that can occur with high fevers that are left untreated for a duration. Not treating a mild fever is okay because some fevers offer physiologic protection. So it's really based on both the need for symptom relief and then the absolute number of that fever. In both fever relief and pain control, Tylenol is more effective if it's given routinely. So if you're treating acute pain, you shouldn't have any qualms about telling a patient to take it quote unquote around the clock. And obviously if you have a high enough fever in order to get true fever relief and to avoid significant spikes in fever during times of non-treatment, you're going to want to give it around the clock. In terms of chronic pain treatment, Tylenol is safer than any other agent that's out there, but it's not necessarily the most effective. So that's a great point for the book to make, but a lot of patients with chronic pain aren't going to get by with just plain Tylenol as the treatment choice. I also feel like I will be doing the book a disservice if I don't at least touch on osteoarthritis. So osteoarthritis can be categorized as either non-inflammatory or inflammatory. So non-inflammatory osteoarthritis is characterized by pain and disability-related complaints as the only symptoms. The physical findings would be tenderness of joints, bony prominence on joints, or crepitus, which is the crackling, crinkling, or grating feeling that occurs under the skin of kind of bone rubbing on bone. The treatment of choice of non-inflammatory osteoarthritis is Tylenol. And that makes sense because Tylenol doesn't have any anti-inflammatory action. Inflammatory osteoarthritis, which is actually what I remember learning about more in pharmacy school, is characterized by joint swelling, morning stiffness that lasts for more than 30 minutes, and night pain. So to me, that's the characteristic definition of osteoarthritis, is the inflammatory kind of branch of it. And here, the obvious treatment of choice would be a non-steroidal anti-inflammatory drug. And our textbook points out that most commonly naproxen is the drug of choice for these people. Naproxen is pretty great in that it has fewer side effects when we compare it to some of the other non-steroidals. It doesn't really have the cardiovascular risk that the COX-2 selective agents might possess, and it has a great duration of action in that it can be taken twice a day, which is obviously more desirable than the 4 to 6 times daily that patients would need to take ibuprofen in order to keep on top of their pain. As a side note, some patients for osteoarthritis or really any type of joint-related pain will inquire about glucosamine and chondroitin. So there's really not a whole lot of risk for using glucosamine and chondroitin, but to be honest with you, there's not a whole lot of evidence either. Some people swear by it and some people can't tell a difference. I think as a practitioner, it's very reasonable for you to let patients know that it's not a problem for them to try it, but that if they notice no difference after 6 months of continuous use of a glucosamine chondroitin product, they should probably discontinue use of the agent, because noticing no difference at that point leads me to believe that they're probably not going to notice a difference at any time point past that, and they're really then just throwing their money away. Moving then to agents that treat moderate pain, we should keep in our peripheral brain the opioids of codeine and hydrocodone. The opioid analgesic pharmacologic activity of these agents really depends on their affinity for the opioid receptors. The way these agents work is that they bind to the opiate receptors in the central nervous system, inhibiting the ascending pain pathways and altering the perception of and the response to pain. So I think a great way to think of this and a great way to explain it to patients is that you're not eliminating pain, but you're decreasing the unpleasantness that's associated with pain. So I like to explain it to my pharmacy students and to my patients on the surgical unit as you get this pain message, but you're very zen about it. You're like, I'm in pain, but it's really not bothering me right now. So it helps alter your perception of pain. The ascending pathway, just so you know, is from the body to the brain. So it's the message that's coming into the central nervous system. I think it's good to kind of have a root understanding of all of these things and not just memorize the words that are there. A great agent to treat moderate pain is actually tramadol. Tramadol is classified as a central analgesic, and it works by binding to the mu opioid receptors. It also inhibits the reuptake of feel-good chemicals that are surging through our system, norepinephrine and serotonin. So it works a little bit differently than the pure opioid agonists of codeine and hydrocodone. It's stated that there's no real advantage of this agent over other agents to treat moderate pain, and that may be true, but we sometimes prefer it in older patients because it doesn't make them feel as foggy or out of it as those codeine and hydrocodone products can. It's quote unquote considered to be a little bit safer with respect to the CNS side effects that may result from some of the other opioid agents. Commonly, the side effects that are associated with tramadol would be dizziness, headache, and the GI complaints of constipation and nausea. But I'd like to put a side note that the constipation that patients may experience with tramadol doesn't really even hold a candle to the constipation that is definitely experienced by patients that are taking opioid medications. As a side note, it is important to know that tramadol can decrease the seizure threshold, so it has to be used very cautiously in patients that have a history of or who currently have seizures, and it has to be used in caution with other medications that can lower the seizure threshold. So if we look then at the group of the opioid agents that are used to treat moderate pain, I've called out here codeine, hydrocodone, and tramadol. So the onset of action for codeine is about 10 to 20 minutes, and this is all oral doses, by the way. Hydrocodone takes about 30 to 60 minutes for patients to start to perceive pain relief. Codeine peaks in about a half hour to an hour and has a duration of about 4 to 6 hours, and hydrocodone follows a very similar model for that. The common side effects of codeine and tramadol codeine and hydrocodone would be drowsiness, constipation, dizziness or lightheadedness, and GI complaints. So I think you're going to notice a common theme that all of these agents for moderate and severe pain have very similar side effect profiles. All of the agents that I've just talked about are actually more efficacious if you use them in combination, and the most common combo product is the opioid agent plus Tylenol or tramadol plus Tylenol. So previously, Tylenol plus hydrocodone was called Lortab or Vicodin. Since they've reformulated those tablets to contain a lower dose of acetaminophen, each tablet now only contains 325 milligrams of acetaminophen versus the old school 500 milligrams of acetaminophen. It's now referred to as Norco. So as a practitioner, it's very important that you don't write Lortab or Vicodin anymore because there's all sorts of crazy rules in the world of pharmacy that says if we get a prescription for Lortab or Vicodin, even though we know those agents don't exist anymore, we have to call you and say, did you mean Norco, which now has the lower dose of acetaminophen in it? So we can thank, the modern government for that. But point being, call that product Norco going forward. Tylenol number 3 then contains codeine and acetaminophen. I believe its ratio is 30 milligrams of codeine with 300 milligrams of acetaminophen. And then Ultracet is the combination of tramadol and Tylenol is what we'll refer to it as. And that has a lower dose of tramadol in it than what we would prescribe if we were just using tramadol as a solo agent. So you'll see that, I believe, in the next slide. So these are some common dosing schemes of agents that are used to treat moderate pain. These are worth committing to memory. Tylenol number 3 is dispensed as 1 to 2 tablets by mouth every 4 to 6 hours as needed. Norco, the most common moderate pain dose is 5/325, 1 to 2 tablets every 4 to 6 hours as needed. But as a side note, Norco also comes as 7.5/325 and 10/325. So the 5, 7.5, and 10 milligram components are referring to the amount of hydrocodone that is in that product. You'll notice that the amount of Tylenol stays fixed in all of the different dosing options. Tramadol, when dosed by itself, is 50 to 100 milligrams given every 4 to 6 hours as needed. But when we combine tramadol with Tylenol, which is the setting of Ultracet, the amount of tramadol is decreased to 37.5 milligrams combined with 325 milligrams of acetaminophen. Again, given as 1 to 2 tablets by mouth every 4 to 6 hours as needed. When we talk about agents that are used to treat severe pain, then we're going to focus on the opioids of morphine, oxycodone, hydromorphone, and fentanyl. So morphine is sort of the standard to which all of the other strong opioids are compared to. And it's actually considered a first-line agent when treating moderate severe pain. So severe pain probably that sits on the camelback of 7 to 8 in the numeric pain scale. Oxycodone has similar potency to morphine, but it's an excellent oral option for moderate severe pain control. It's available both as a long-acting formulation, which is called OxyContin, and then a immediate release formulation, which brand name is Roxaset, which can be used for breakthrough pain for patients. Hydromorphone then is definitely more potent than morphine. Other than that, it has no real appreciable advantages. It makes me pretty nervous when I see practitioners prescribe oral hydromorphone for patients. I think that oxycodone is a safer option, and even morphine and extended relief morphine would probably be better utilized in the primary care outpatient setting. Fentanyl is a really good opioid for chronic pain because it comes in a dosage form known as the fentanyl patch. So that allows for a slow, steady release of fentanyl topically that is then absorbed through the dermis and allows for a more moderate level of drug delivered to the system for pain control. Of note, I have had patients come into the ER who have tried to eat their fentanyl patches because apparently that gives a euphoria unlike anything else. But the patches are so nasty that I can't imagine ever trying to eat and or swallow one of those. As a side note, there is a population in which morphine may not be desirable. Patients that have underlying pulmonary disease or who have a compromised respiratory system could actually be more susceptible to the adverse effects of respiratory depression that morphine can cause. Additionally, we should avoid morphine in patients who are chronically on CNS depressants or patients who have a history or a current issue with alcoholism. So I think it's kind of neat to call out patient populations that might not do so well on a drug, like seizure patients and tramadol, and then pulmonary disease, CNS depressant agent using patients or patients that have alcoholism should avoid morphine. So the chart then that talks about agents to treat severe pain, you'll see that morphine has an onset of action of about 10 to 20 minutes, and that matches hydromorphone. Oxycodone takes a little bit longer at 30 to 60 minutes, and then oral fentanyl, which isn't really utilized all that often, has a really quick onset of action of 7 to 15 minutes. However, its quick onset of action also leads to a really short duration of action of only about 1 to 2 hours. Again, that's oral fentanyl. Fentanyl in the formulation of a patch works much longer, and we'll get to that in the next slide. Again, you'll see that the common side effects include lightheadedness, GI complaints of nausea and constipation, and then some itching. You'll notice that for the majority of the other agents, morphine, oxycodone, and hydromorphone, our ballpark of about 4 to 6 hours of analgesia duration is a good thing to just kind of keep in your mind. So common dosing schemes for these agents that we use to treat severe pain are as follows. OxyContin, which is the long-acting formulation of oxycodone, is dosed as 10 to 20 milligrams every 12 hours. And you'll notice that I didn't put PRN here. If we're giving a long-acting agent, we want the patient, at least for a short period of time, to take it routinely so that we can stay ahead of the pain. One of the biggest issues that we get that comes up when we're treating pain is that patients wait until it's too late to control their pain. And so I like to think of it as like climbing a mountain and you've almost made it to the peak, but then all of a sudden we're in this like weird Fantasia movie and the peak moves even higher. And you're never going to get to that summit and overcome that peak of pain control. It's just going to keep getting out of the grasp of your analgesic agent because you've let the pain kind of get too far. So scheduling long-acting products is actually helpful in the treatment of acute pain for patients. The cool thing about oxycodone is that you can use OxyContin, long-acting, in combination with short-acting oxycodone, which, as I referred to earlier, was Roxaset. So that can be dosed as 5 to 10 milligrams every 6 hours as needed for quote-unquote breakthrough pain. It is not necessary to use the same agent for breakthrough pain. Some patients will actually find more relief if we're using a different agent altogether for breakthrough pain. MS-Contin, which is the extended release morphine, is dosed as anywhere from 15 to 60 milligrams, again, given on a setup schedule of every 8 to 12 hours. I have seen patients on 60 milligrams every 8, but the way we generally think of dosing ranges is that the lower dose is given more frequently, and as we move up the dosing ladder, we then also extend the interval. Lastly, fentanyl patches, which are applied topically, deliver enough drug such that they are changed every 3 days. I've seen a few end-of-life cancer patients get their fentanyl patches changed every 48 hours, but the mechanism by which they release the drug, they are designed to be changed every 3 days. So at the beginning of our lecture, we talked about pharmacologic therapy, obviously, but I think it's important as a primary care practitioner to keep in mind that there are other modalities for pain control that we can educate our patients on and help them access. If fear or anxiety is determined to be a large component of a patient's pain, it might be helpful to prescribe something like lorazepam or alprazolam, which are anti-anxiety agents, to help augment the relief that they're getting from a pain control agent. It's important to counsel our patients about cognitive or behavioral techniques that they might be able to do. So relaxation techniques when they're experiencing pain, stress management that might help them in terms of their chronic pain. And then lastly, the obvious non-pharmacological treatments of ice packs or heat packs, depending on what the quality of the pain is. And then there's a lot of information out there that massage does wonders for people in terms of pain, especially chronic pain when we can't really pinpoint it or we describe the pain as really vague. We're going to finish up then with a few quick slides on chronic pain. So 50 million Americans suffer from chronic pain, and chronic pain really arises from physiologic changes in the nervous system that are caused by untreated or undertreated persistent acute pain. So it's important that we treat acute pain correctly and that we follow up with patients to make sure we've treated their acute pain. Otherwise, we can morph that patient into chronic pain. It's important to note that for chronic pain, oftentimes there are unidentifiable triggers. It's hard for patients to describe where this chronic pain comes from and kind of what makes it better or worse. We should know that chronic pain can be expressed as fatigue, depression, sleep disturbance, decreased appetite, or increased irritability. So when you're monitoring your patients, it's important to pick up on these other sort of like obvious cues that they're experiencing chronic pain. Long-term management with opioids may significantly improve a patient's quality of life and their ability to participate in daily function. And if you're going to use opioids for long-term pain management, it's probably best to consider the long-acting formulations. Primary care practitioners shouldn't shy away from treating chronic pain. You can kind of learn to feel comfortable and train yourself to feel comfortable in treating chronic pain by helping set pain control expectations with the patient. We talked about that a little bit earlier. Getting a chronic pain patient to, kicking their heels up and being incredibly pain-free all day, every day is not realistic. We also want primary practitioners to prescribe medications in a responsible fashion. Reassess the patient's symptoms frequently and specifically using the PQRST, and don't send them out the door with a prescription for 100 tablets of Tylenol number 3 when you haven't really assessed if that's the agent that's going to be best for that patient. You're going to get yourself into trouble when you just start filling out prescriptions for controlled substances for patients. If you're the type of practitioner that doesn't hold back from treating patients but treats them responsibly and respectfully, you're going to feel more comfortable treating those patients because you're treating their pain from a place of science, not just from a place of like, oh geez, I got to help this patient overcome their pain, but I also want to turn them into an addict. If you're comfortable and understand sort of the science behind it, you're going to be a better practitioner for your patients. You also need to recognize and treat the exacerbating factors that may limit a patient's success in achieving total control of their pain. So treating their insomnia, treating their depression, treating their anxiety. If you've tried a number of analgesic agents and it just doesn't seem to be helping and the patient's having a hard time of pinpointing why it is or is not helping, it's perfectly acceptable to tack on an antidepressant for those patients or to give them a PRN anti-anxiety medication. We sometimes also have to go outside the box of just regular analgesic agents. So things like tricyclic antidepressants, amitriptyline, for example, not only does it have antidepressive qualities, but it also has some pain control qualities to it. We see it used a lot actually in diabetic peripheral neuropathy. Other agents like gabapentin, which is called Neurontin, or Lyrica, which is called pregabalin, are kind of sold under the heading of anti-seizure drugs, but we never use them really anymore for anti-seizure. We use them for neuropathic pain because they alter the pathways in the central nervous system that deal with the perception of pain. So those are other things to think about when we're thinking about chronic pain as well. Experts agree that addiction is generally not a concern. If you're prescribing responsibly, if you're educating patients, and if you're following up, we don't have to worry about patients becoming addicted to the medications we're supplying them. It's interesting to note that chronic pain actually leads to pain medication misuse because patients will consistently treat pain, but they do so suboptimally. So they think, well, I have chronic pain. I know it's never going to go away. So I just keep taking this medication. It's not really working for me, but I don't know how to vocalize that to my practitioner. So I'm just going to keep taking it. And with time, you expect patients to develop a tolerance and a dependence on a medication. So a tolerance is when you kind of reach the maximal effect of how that drug works in your body, and over time it actually decreases and becomes less effective. We expect that to happen when patients take opioid medications. On the same hand, patients do become dependent on that medication. Physiologically, things happen in the system and in our body that when we take that medication away, we experience withdrawal. That's totally different from addiction. We expect patients to experience tolerance and dependence. So in chronic pain, we need to work with patients because eventually it's possible that a pain medication won't work for that patient anymore. And if we just let them continue to treat their chronic pain with that agent, we're now suboptimally treating their pain, potentially increasing the risk that that patient will say, well, I've always taken 2 oxycodone, I may as well start taking 4. 4 is not working, I may as well start taking 6. So keeping that line of communication open and consistently and conscientiously reassessing your patient's pain is going to make you a better practitioner and is going to result in better outcomes for your patients. To wrap up this lecture then, we'll talk about a few quick tips on discussing pain control with your patients. Educate your patients to take the medications that you're prescribing exactly as you've prescribed them to help avoid overdose. Counsel them on the very common side effects that they can expect to see, the prime one being constipation. And I think it's your job to remember that you're going to have to recommend over-the-counter agents that will help prevent or treat constipation. You should also remind patients that it is not uncommon to experience dizziness, nausea, drowsiness, or sweating and flushing when using especially opioid analgesics. If we don't counsel patients on those things, they'll assume that this is a catastrophic event for them and they'll stop taking those medications. And oftentimes patients then won't take any medications from that class because they had these quote unquote bad experiences with the medication. And then remind patients that especially in settings of acute pain, short-term use of pain medications is actually way more beneficial than being the strong person and dealing with the pain or working through the pain. Pain medications are there to be used appropriately, and when we educate patients to that, you're many steps ahead than dealing long-term with patients who have this chronic nagging pain.